Welcome to Your Inheritance, your rights, your obligations, your responsibilities, with your host, Peter Bochnewich. In each episode, you'll learn insights from experts. If you're being sued over an estate or if you feel you're not getting your share, Peter's firm can help you. You can find this show at www.betrustlaw.com and on YouTube, Facebook, Apple Podcasts, Spotify, Google Podcasts, and more. Now here's the host of Your Inheritance, Peter Bochnewich.
Hello and welcome to Your Inheritance. Welcome back to our podcast. I'm Peter Bochnewich. I've been practicing attorney in Southern California for 33 plus years, primarily dedicated to trust and estate matters, deal with a lot of issues affecting our elder community. And my particular practice focuses on a lot of inheritance disputes in court. I'm a trial attorney, and we deal with a lot of issues affecting disputes over inheritances, but we also deal with conservatorship matters and a lot of matters in estate planning and matters for planning for when folks get older and what happens when our parents, grandparents get older. And we're going to explore a topic that raises questions for many children. And how do you provide care for an aging parent, an aging spouse, an aging partner, husband, wife, partner, or any loved one? And our very esteemed guest that we have with us today to discuss these issues from a boots on the ground care providing perspective is Jenny Johnson, registered nurse. Jenny's got 23 years in the nursing field. She has a company called Heart of Gold Nursing. Probably here. Hope someone's not having an emergency there. But there we go. That we have that every once in a while. But Jenny is Heart of Gold Nursing in Palm Desert, California. And I know Jenny through the Desert Estate Planning Council, where she is an officer and on the board. And she has great experience in providing in-home care services for elderly clients of hers that need in-home care. And she's been doing it for quite a while. And she's been a nurse, like I said, almost a quarter century. And she's got a very vibrant business and has a great reputation in the community for what she does. So Jenny, thanks for being on board. Welcome to Your Inheritance.
Thanks for having me. I'm excited.
Okay, Jenny, first thing, let's talk about your care providing service. What is Heart of Gold Nursing?
Heart of Gold Nursing was an accidental start, meaning I never knew I was going to be an entrepreneur, never knew I was going to start a business. Life has a way of having twists and turns, and I was given this opportunity in 2020. I just started it as a concierge nursing firm and was raising 2 kids at the time. And I sought out clients who needed, or patients who needed care after usually surgery. And so I would maybe have about 8 of those clients a month, just taking care of them post-discharge, plastic surgery patients, etc. Most of my career was in critical care, so that was super easy for me. So that was my first service line. I did that for a couple of years. And then in about 2022, I was getting some traction and people started calling me about care providing. We call them care providers, caregivers. And I didn't have that service then. I just would quickly Google places that had great reviews and send them their way. But ultimately decided to bring that in, which we did in 2022. And quickly after that, I saw that people were calling me, I need someone to help my mom. She keeps falling. Okay, so I would send out a care provider, and then I was realizing no one's really asking, why is mom falling? And caregivers, it's a task-based service. Maybe I'm sure we'll talk about this. It's not a solution-based service. So then with all my nursing experience, it was quickly easy for me to just say, what blood pressure pills are you on? Or has your mom had physical therapy? Ultimately, I created something called care management, which it is actually a legit profession. There are many companies across the US that do it, but we come in and really find out the why behind things versus just the tasking. Hi, we're going to help mom get from the chair to the shower safely. So we really explore those ideas as to why are those things happening. So in summary, we still do the concierge nursing service. That's all private pay, registered nursing services. We do caregiving services, and then we do geriatric care management.
I'd like to break that down a little bit because what you said is very interesting. Because in my practice, I run into care providing situations all the
Mhm.
time, the pluses and the minuses of that. But one of the things I'd like to focus on is your experience as a nurse. This is an observation of mine. There are care providing services out there. I'm sure everybody does their best, but
Mhm.
times you have care providing services where maybe the people who are in charge do not have the depth of experience that you have as a registered nurse. You mentioned critical care. You mentioned that you were in the hospitals helping with people and all that sort of thing. And you started out providing care to people. I guess it was after they had an operation or something, they would go home and you would be providing that service in the home, or is it in facilities as well? Describe that background experience for us.
Yeah, to me, just being an ICU nurse for 15 of those 22 years, everything just is so innate and ingrained in me now. So it was an easy transition to take care of people post discharge. But not everybody needs a nurse or wants a nurse. It's a heftier price tag for one. So I can't always afford it. But number two, they don't really need a nurse indefinitely. So it was easy for me to transition to the caregiving. But where I saw the gap in care when it came to my gut feeling and my innate thing, like I can just look at somebody and tell typically what kind of distress they're in. When we transitioned to bringing in the caregiving, frankly, I didn't realize the gap in care that would happen. People call and they think that a caregiver is going to be their ultimate solution. And I don't ever get calls with people who are not in crisis. Typically, they're always calling because there's a big problem.
In
And
crisis, when you say, there are a couple things you said there, because you're a
Mhm.
very technical person, you've got a great medical background, and you said you're running by these terms like ICU. You were in intensive care unit. You worked in intensive care unit, so you know how to spot issues affecting people as well as a nurse can. And when you're providing services or assessing a situation, and you may not be able to assign a nurse to that person at their home, but you can go in and say, hey, this is what this person has affecting them, an elder parent. They want to live at home. What do we have to do to really develop a plan that suits their needs, that actually suits their circumstances? Is that pretty much what you do?
Yes, not only spot it, but have those difficult conversations. That is another piece of this puzzle that is huge. Being willing to go in and have honest conversations with families and even clients about what they need to have. And we're not always the solution. Sometimes I need to. We just had one a couple weeks ago and it was hospice. That's a scary word to some people. Actually, he ended up passing peacefully and she called me and thanked me afterwards because even I've been finding even medical providers, doctors don't have those honest conversations, and by the time they get to us, they can either be really sick and needing a lot of extra support. So that's, again, we'll touch upon that. That's where the care management comes in. But so having those honest conversations, but also, yes, having that gut feeling of what these clients need.
If you were to say a mission statement that Heart of Gold Nursing might have, do you have a mission statement that you?
Absolutely. I always say we are a solution. I always want to be a solution. So we're not just providing care, we are always providing solutions. In a very simple term, I take that from the time that phone call comes in. Okay. So that phone call I got about the hospice, she was telling me her husband was bedbound, wasn't eating or drinking anymore. They had an appointment the next day with the oncologist to discuss what the next steps were. And I literally said, honey, you don't have time to wait till tomorrow, and referred her to a local hospice that I like to work with, but in addition gave her those next steps on how to get to that hospice solution. Ended up not even needing me. That's what she ultimately needed. So that's an example. The other thing is I always want to be a solution to my care team. So it's not just our clients. I want to be an amazing solution to those in my organization that are actually providing the care. And I don't mean just the tactical solution of our processes and making things streamlined, but that my care providers are going to homes where they can be a solution and that they can be the right fit for the clients that we serve. So it's not just a warm body, we're not just a transaction. That is one of the biggest things that helped me want to grow my service lines. I was a mom first, and I always called my business for the first 2 to 3 years my mommy side hustle. I was raising 2 kids, but I organically grew this business because I was seeing the gap in care. And it's not just in our area. I'm a part of a few nationwide organizations where we all collaborate. There, I hate to say it, but I'm going to say many, I feel like, places that it's a transaction, it's a warm body, it's Mom calls, daughter calls, mom needs care, get them out there, get a warm body. It doesn't work that way in home care, in my opinion.
I want to break that down a little bit because you touched on something that I think is very important. And this is not me being critical, or certainly every business that provides, or every service oriented business that provides in-home care, there's going to be a great variety of them because there's different price points and there's different needs. But sometimes one might get the impression that whether from top to bottom and even at the actual point of contact with the client or the patient, the person being taken care of, that yours is going to be more than just like watching or being a babysitter or something like that. And I don't mean to use that term in any way pejoratively, because there's a lot of great care providers out there. And I've had in-home visits with clients and they do the best they can. But what you're talking about is something that's more comprehensive that your service provides. I'm just going to give you an example. You go into a home and someone has a problem with falling, problem with mobility. And I had a situation where someone had a very modern home with a lot of angles and a lot of sunken floors and this and that. How do you deal with that do you come up with a plan to make recommendations on how people are going to get around in their home? You need to put a ramp here, you need to do this or that. How deep do you get into that, if you can tell us?
That is such an awesome question. So I 99% of the time will not take on a client unless I've seen their house. The only time there's an exception, obviously, if they're a snowbird and they're coming down here and they already know they need care, we have different systems for that. So we always go out and meet the client first. We do a comprehensive assessment. I built our care provider assessment. Remember, care providers are non-medical, but I still built around that assessment around like the nursing process. And again, it's just because it's innate in me. So one of them is obviously safety. And again, with that solution focused mindset, providing solutions either prior to starting care or as care is commencing, we are building in those solutions. So the simple one, you're absolutely right. Falling is such a huge thing. And in fact, it's an epidemic right now. If you are a senior that falls, you are considered a trauma patient and you head to Desert Regional Medical Center for that, no matter how bad the fall is. But with that said, so obviously checking showers, the high risk areas first, the main pathways where that person is traveling throughout their home. I check the height of the bed. I actually visually, we see them get up and down. That is something I like to see. If they can't get up and down, then that's even a bigger problem, right? But there are ways we can modify it. And in the end, it actually can save them money down the road, because I'll get a call, we need 24/7 care. That's a huge price tag. But me getting out there, they might need it for the time being, but maybe they just don't have the modifications in the home yet to be able to support some of those safe moves around the home. Clutter is a huge one. Our seniors love to start just making piles of things around their house. We've gone to clients' homes and the stove was not turned off all the way. So there's smell of gas, because as we age, we don't smell the way we used to, or the memory. They don't even remember they cooked dinner. I could go on and on with a million scenarios, but that's exactly why I mandatory go in and we need to be able to see our client firsthand. The other thing, I want to be able to pair the right care provider with the client. If I have a 280-pound male, I'm not going to send out a little 5-foot caregiver who is amazing, but she can't logistically support transferring that. So I have to make sure it's safe for my team as well. So there's so many factors that go into home care.
Right. So it's not just having someone there to assist. It's someone there having the capability to assist that person, and having some level of suggested infrastructure in the home, whether it's to clean it up or to put some implements in place, railings, or different things, that access to the doorway, or enabling people to get in and out of the shower or whatever. Those things are very important. And you do that in like a survey at the front end of the engagement?
Yeah, I wouldn't call it a survey, but yes, it's literally like an assessment. We have a template that we've created, so we make sure we hit all of those points. And we're often the first call. So I always say, when we call a doctor for a foot injury, okay, we're calling a foot doctor, right? So these people are actually calling me. I need to guide them with the expertise that I have to be able to guide them for their care solutions. And I encourage them actually to call a couple agencies, because I tell them home care is a very personal thing. We are coming into your world, your way of being. We need to be able to adapt to you. If I don't know you well from the get-go, medically, and even how you live your life, it's so silly, but even the temperature of a home, these are all the things I've learned along the way. It matters. Our seniors love a 95-degree home in August. It's crazy. Our caregivers can't handle that. It's these minute little things that comes down to it just can't be a transaction. It's got to be a way of being. It's got to be a way that we can immerse ourselves into their life respectfully and professionally, but also solutions focused for safety for all around.
Yeah, our viewers out there will be watching. We have a pretty broad viewer base. We're talking large part about the circumstances here in the Great Desert region of the Coachella Valley, but these kinds of things, these kinds of looking at the environment, the home environment, to tailor make the provisions of care to that environment would apply in any circumstance in any state or region. As far as personal care goes, does Heart of Gold Nursing, what kind of assistance do they have? They provide to seniors at home when they need it for the activities of daily living. What could you describe about that?
Yeah. So the easiest way to say it, yes, I've said it already, but it's task-based. We give them almost a checklist of things that this client needs based on our assessment. So ADLs is what we refer to it, activities of daily living, but it's the things like medication reminders, showering, bathing, dressing, grooming, feeding, doing those things. And then we tailor a care plan to make it a little bit more specific to the client. So we wouldn't just say, let's see, medication reminders. We actually want to take a slightly deeper dive and maybe mention some of those, that obviously the times of day, if there's any interactions, things that they need to watch out for. But those are basically the basic level things that a caregiver can do. We always emphasize they are non-medical. If you are looking for a care provider firm for medical solutions, that is not safe. They're great. They are experts at what they do, but they are not there to do medical procedures or be medical. I do think that's a mistake and a misconception that people don't understand. A lot of times too, they think they're calling home health, but it's home care. And unfortunately, those are used a lot interchangeably in this industry. So there's a lot of education behind that. But I, ad nauseum, emphasize they are non-medical. It's like me as a nurse, though. Don't ever put me in obstetrics. And I use this example all the time. I would not know what to do. It's the same thing with caregivers. We do not want to put them in a role that they have never done and do not have that expectation of them.
They're not doctors. As a nurse who is a CEO of the company, doing the initial assessments and so forth, you will evaluate things, but this does not supersede proper medical care from the primary treating physician at all. And do you work in conjunction with them? For example, someone's living at home and maybe they're having a little bit difficulty. They've got to the point where they are not good at administering their own medication. You don't prescribe medication. You're not a physician. You can't do that. The care providers who are there, boots on the ground, can they assist the elder in those kinds of tasks of getting their medication every day?
Yeah. So in California, the rules are they are not allowed to literally put their hands in a bottle and dispense like that. Hi, Peter, here's 2 of your blood pressure pills. Because technically that's considered a skilled, they're dosing the client. And I use that actually example a lot because caregivers wouldn't even probably think necessarily, let me check the blood pressure before I give them a toprolol. You know what I mean? Or the client is dizzy, so I need to check the blood pressure. It's very task-based. But so what we do for medications, it's a simple fix. We just put it in a med box for them. But we need to make sure that there is somebody competent besides caregivers to be able to put them in med boxes. So that's either a family member.
When you say med boxes, so let's not assume that everybody knows what we're talking about. We know what we're talking about, but it's a simple thing, but it's an important thing. It's the little box that has the pills laid out every day, and you want to make sure that you get the right pills in the right day in the right amounts, and that you're putting everything's correct. And so, who does that, and how do you make sure that's done properly? If you could describe that.
Sure. One thing I want to point out as a red flag, and again, going back to my organic business growth, is showing up to clients' homes where I've seen they've either hired a private caregiver to manage it, it is not done correctly, or obviously family members don't always know why a med should be given at a certain time, or coming from another agency where they had caregivers dispensing meds. And that's such a huge red flag. So I just want to point that out. And I've seen that many times. So there's that. I went off on my tangent there, Peter. What was the backup question of that? Because I was thinking of that as you were sharing.
Just basically the methodology of it's so simple, but it's so important. You got to make sure if an elder has to make sure maybe they've lost track of how to do it themselves. And so now we're going to assist them. What's the methodology? What's the protocol from your perspective? And again, we're not giving medical advice. We're not giving legal advice, and we're not giving medical advice on this podcast. We're just talking about practical, everyday realities of in-home care and considerations that have to be made. It can't be it's a simple thing, but it's so important to
Absolutely.
make sure that when the grandma or mom or dad is getting the right pills on the right day, and maybe even at the right time, and maybe spaced if it's supposed to be recommended after a meal or before a meal or whatever. What's your methodology to follow the doctor's instructions or to implement that plan in the home?
Sure. So what we do on intake, but this is actually legitimately one of our questions, will you need medication reminders is what we call it in California. And then if so, who is going to be managing the medications? So we find out if they have a person, if the client is not capable of doing it themselves, then we will, okay, is there a local family member that's helping them? We go through the process. We even ask what medications they have so that we are aware of that. We even ask what pharmacy. If there is not a local person, that's where care management comes in. And that's the beauty. And I never realized how beautifully my service lines would work together. Again, I just saw the need and I was like, little Betty needs help with this. And I'm a nurse. So it was just easy for me. But that's where I can offer them that solution. Hey, you really need a care manager. There is no local family here to support you. You have Parkinson's. Parkinson's is a timed medication. If you don't take that every 3 to 4 hours, your tremors will increase, which means you're much risk for falling. It's a whole cascade of events. And again, if we're talking money, because that's such a big factor when it comes to home care, 24/7 home care in Riverside County, there's a Genworth website you can go to. It's about $26,000 a month minimum. Okay. In Coachella Valley, you're looking at about 30,000. But if you can just tweak some of those things, for example, the Parkinson's, this is actually a real client that we've had, and fix those things, solution focused, you can eliminate some of that extra money that you're having to spend just by what you're talking about, correcting the medication mismanagement. The other thing our seniors do is they love to doctor shop. So Dr. A, Dr. B, and Dr. C, they don't talk to each other. A care manager can come in and get everybody on board. And frankly, they love us because our seniors love to go in. They get 10 minutes with modern medicine, unless they're blessed to have a concierge doctor, but 10 minutes to crank it out. And our seniors, they take forever. They want to go on and bless their hearts, but that's just not the way medicine is now. So we come in, we've got the med list ready, we've got the symptoms, we've followed through on what the side effects have been, or we'll have blood pressure log readings, trends, timelines, going down a whole other rabbit hole here.
Are you saying that you go with them to the doctors?
Yep.
Okay.
Yeah, if they want us to, we do assess in the beginning, like, what do you want us to do as a care manager? But it's pretty heavy-handed in the beginning, and we recommend that. People who need our care management service, very often, it's chaotic in a lot of areas of their life, and medically is usually the number one.
At the start.
At the start, yeah. Let us go to your main doctors. It's usually primary care and whatever. Let's say if they're having cognitive decline, I'm going to want to go to their neurologist as well.
You go with the patient. You go with the client. Well, it's actually a client for you. And I just want to emphasize, you are not diagnosing, you are not prescribing, you are learning, and you are implementing what the doctors want for these folks in their home. I do want to also touch on it. Some of the numbers that you've mentioned in terms of what the price range might be is high. It's, I'm sure, well worth it, but it is high in many respects. We'll talk about what can be done for folks who can't maybe afford those $20,000 or $30,000 a month to stay at home. Mm-hmm. At some point, there might be a time when, if you can't do it, you're looking at probably going into a fine facility that could be able to provide the care if family members can't take someone in at home and cooperate to the assistance of the elder in that way. But before we get to that, I'd like to talk a little bit more about some other things that are very important in the needs of daily living, if you will. We've talked about comprehensive medical, the prescription medical, again, following doctor's orders and make sure that these are delivered accurately and timely and properly and preferably at the doctor recommended times of days and at those circumstances. Your service is able to assist in doing that. What about nutrition and meal planning, and what does Heart of Gold do in that regard?
Yeah. Again, it all goes back to that nurturing from the very beginning and assessing them from the beginning. We always ask, obviously, if they have dietary restrictions, if they're having weight loss, which is another common one we get. Sometimes, have you been to the dentist lately? You'd be surprised how many of them are missing teeth or have toothaches just from not going to the dentist. As we age, it seems to be something that slips their mind. But with that said, yes, definitely supportive on nutrition. That usually always goes on our care plan. We base it around what they've told us. Again, if they're diabetic or they're having cardiac issues, heart issues, do we need to modify the diet for that? And then going back to pair with an appropriate caregiver. Some of our clients want somebody that knows how to cook. So we put that in the care plan and find an appropriate match. So that's as far as the cooking and the nutrition and the dietary.
Do you ever run into a situation where someone may be prohibited from certain things, but they still want to do it? Someone's not supposed to consume alcohol anymore, and I don't know if there's practical, you can't mention any names, can't mention any specific circumstances, but in the whole area of nutrition, people want to eat something they're not supposed to eat. People want to drink something they're not supposed to drink. How do you handle those boots on the ground situations?
So if they're alert and oriented, it's their life. We're not there to control them. And in the sense of I always tell them, like, you get to be the independent person that you are. We're not coming in to babysit you. We're not coming in to take over your life. And in fact, I want this to be collaborative. So there's that. And it does seem to be like a lot of our clientele have lived very prominent go-getter lives. So it's really hard to break through to them. The alcohol thing I do want to touch upon, because that is actually a lot more common than you think. I'll tell you in a couple of the circumstances that we've had. We have one right now. It would be very unsafe to just play around with that. She would go into withdrawals, and that would be an unsafe thing. We've collaborated with the son who lives out of state. He's fully aware his mom has that issue, and he's, look, let her do what she's going to do. This actually brings her joy, and she's not unsafe. We have 24/7 care or whatever. We had another client.
It doesn't interfere with, you want to check that out with the doctors and so forth, because maybe there's something that you don't want to have someone taking something that they're not supposed to take with alcohol, obviously.
Absolutely. And she's got 24/7 care. She's not going to fall. No, I don't want to spend the time going too deep into hers, but it is actually an appropriate solution for her. And it would actually do more harm than good in this case.
This is a hypothetical patient.
Hypothetical. There we go. But we did have another one. They've since passed, where the daughter was very much on board. And what we did to wean down on that was she sent all the groceries to the house. We didn't even do the groceries. She did mobile order, and she had instructed us we would mix the non-alcoholic wine with the alcoholic wine and mix them together and wean them down. But it's a really appropriate thing. It's not always safe to just cut them cold turkey. But even on dietary stuff, that's not really fair. If they're 85 years old and been eating the way they want to their entire life, and suddenly Heart of Gold's going to come in and you get no salt in your food and no sugar because you've got a bad heart.
Right. Well, and Heart of Gold, I would just say this. It seems to me, I'm extrapolating from what we're talking about, you're dealing with family members that are going to have their suggestions, and that's going to be with the authority of the client. But unless they're conserved in a conservatorship, and you're speaking to maybe a private professional fiduciary, I don't know if you do that, or a conservator, I don't know if you do that, you're really taking your orders from the client who just needs assistance. They're they're free citizen of America, and you're there to help them follow their doctor's orders, but you're not dictating terms to them. Right?
Absolutely. That is exactly it. And that's where home care is a special niche. That's why I said a little bit ago, we are going into their home and in their way of being. And there is also a strategy about if you really do want someone to have a better quality of life. It's not manipulative, but it's very, I know I wouldn't want somebody just coming in and telling me what to do. So we do like very slow collaborations and slow tweaks. The whole goal is to get them to age as independently as possible and as safely as possible. And that's how we do it. So sometimes it's just one step at a time. Maybe the first thing is just safety. We don't want them to fall and break a hip. So we're not going to really focus on the diet too much then. And then on plus we have to get them to trust us too. Do you know what I mean? Again,
Sure.
back to there, I always love to know what they did for a living. And it doesn't even really matter. All of us have pretty much lived independent lives. And to have an agency come in and start to take over, it's hard on their ego and on their pride, and it's hard to take that help. So we have to be gentle and go in with kid gloves too.
And if they're, like I say, unless someone is given up their rights or had their rights taken away from them, they get to call the shots on their own life. And you work within that framework as much as possible, collaborating with family members in a cooperative way to just provide the best care for the senior in the in-home space as possible. What does the care team do with respect to housekeeping or transportation? Do you offer those services as well?
We do. So housekeeping has to be limited in the state of California. One, I do like this delineation is caregivers are not housekeepers. We've had a
Right.
few that thought that. It's legit in the California code it's through Guardian, the Department of Social Services, is they are not housekeepers. They can spend 20% of their time with the client doing housekeeping duties, and that's specific to the area. So Peter, if you were our client, it would be your bedroom, probably the kitchen a little bit, the bathroom, and probably the living area, and that's it. And even then, it's at a basic level. We're not there to prepare the guest room for the family coming into town and creating these elaborate meals. By the way, this has all happened. Pretty much everything I say has come up with time. That is specific. Transportation as well. We do the transportation. We acknowledge that on our care plan. We only transport if it has been agreed upon. They have to sign a transportation waiver. We do make sure all of our caregivers, they are all FBI background checked. So I will know if they've had a DUI in the past and for which they would probably not be a part of our care team. And if something happened criminally with them, I would be alerted right away. But on that waiver,
So you vet everybody. Yeah.
Absolutely. Yep.
Background
And
checks on every employee.
yes. And I love that it's, like I said, it's the FBI one. It's not just through some little service that I find online. And I like that. And that's a California requirement anyway. And that's the responsibility of the caregiver to get their background checked and submit that to us. And then they have to go through a process with the state to be able to be a caregiver in California. But quickly on the transportation waiver, we do put this on that waiver is that we obviously always make sure they have their license, their auto insurance, and of course they've been background checked. But one thing we can never guarantee you is that they've got their oil changed, that their tires have been changed. But it's the same thing for the client because we can also drive the client's car. We do ask them obviously that it's an insured vehicle. I don't check that their car is insured. I don't have to do that, but I also can't check the maintenance on that. So it goes both ways. My caregivers who work for me, but also it's the client's responsibility to make sure if they want our caregivers driving their car, they have responsibilities as well.
So you've got a bunch of rules and regulations that you've got to follow to provide this service in home. And what you're telling me is you have a system of making sure that you follow them.
Absolutely. But
Okay.
again, at the end of the day, where I always tell people too, I say this all the time, transparent communication. We are a people business. I cannot control. And that's been the hard part for me as we've grown. I can't control what people do when they're out of my sight. Do you know what I mean? And we are in a people business. It is not a product that is done the same way every time, like at your iPhone, right? We're in a people business. There's a lot of variables and you have to have the safeguards in place as best as we can. So the better we nurture them up front, the better they know me up front. That's part of why I like to go out. I want them to trust us. I want them to know our way of being. It doesn't hurt my feelings if I'm not a good fit for them. Interview a few agencies. Really know what you're getting beforehand. The problem I see again is people wait until they're in crisis. I love the clients who say, you know what, my mom is starting to have some memory loss. We're not ready yet, but I'm just wanting to do my homework. Love those people. They're doing the right thing. But nope, most of the time
I agree. In legal practice, I like to give reasonably ample consultations. We do it at no charge for a reasonable time. I'm very ample with mine, But I'll always tell people, get a second opinion, get another opinion. Actually, I'm giving a consultation, and until we're retained, we typically tell people we're not really giving advice, but we do pretty thorough consultation. And I think what you're saying is to build trust, check out what I'm saying, or go to another firm to see if what I'm saying makes sense to you before you retain us. And I think that's a good process because a lot of it is chemistry between lawyer client. It's they're interviewing me, but in some respects we're also interviewing each other because you want to make sure you can have a good working relationship with someone to make sure it goes through in a case. Sounds like it's the same in your field. You've got a team, you've got an approach, you want to make sure it works. You've got rules of the road to make it work for your team so you could do your job. And that might be, look, I'm going to want to be able to talk with your son or daughter from time to make sure that everything's good and we're doing everything right in the scope of the family. And if you run into no, I don't want you to talk with him, maybe we're not the right fit. Do you ever have those kind of dynamics come up?
Immediately. Yes. Thank God that's not that common. But the case that I thought of just that we had, I don't know, it was earlier this year, this individual had nobody except for a friend who was taking care of her, an elderly gentleman himself. He ultimately backed out. We had nobody. Her care increased to 24/7. She had a fiduciary, but this person was only supposed to take over once death happened. It put us in a really awkward position because her care needs increased to 24/7. She was dying, so she couldn't even eventually get out of bed. So here we are now billing and invoicing for 24/7 care, which that's a heftier price tag to look like. I don't ever want it to appear as though we are seeking hours. Do you know what I mean? I want transparency. I called the fiduciary. I'm like, look, I know you're not supposed to be in this case until death, but I need you to know what we're doing. But she literally had nobody. And it puts us in an awkward position. I can't ever guarantee that someone's going to have their person, but it happens. And then that we become the fall guy.
At a certain point, if it's reasonably apparent that someone wants to live at home, they desperately want to stay at home, but maybe they can't live at home anymore because of the expense of it, or because it's just not the right place to be. Do you have that hard conversation with that person or family members? Not talking about specifics, we're talking hypothetically as a matter of policy or a matter of practice. How do you handle that when it gets to be, look, 24/7 with coming to your house all the time is just prohibitive? Do you have a mechanism or do you have a policy where you'll say that? For some people, it might not be prohibitive. It doesn't matter. But for many people, it might be. What do you do? How do you cross that bridge? In
fact, yeah, that's actually not a hard conversation for me to have at all. In fact, they're relieved. Our consumers don't realize what's out there in the possibilities. There's senior placement specialists. I have a couple that I refer to. They are the experts in helping place seniors in different living options based on budget. In fact, my clients are relieved because they don't even know this exists. I personally do not do it within my firm. There are some home care firms that do it. I'm not saying it's wrong, but I don't want it to appear as though I'm double dipping. So I refer to them and I just tell the client, you're doing your homework. You are trying to see what's out there. And then now you're getting all the data. And based on your data, you're going to decide, do I stay at home? Do I go to an assisted living? Do I go to a boarding care? Do I move closer to my kid in New York? Because I can save money that way. So I find that most people are very relieved that you even thought outside the box a little bit to be able to help support them in their aging journey.
And I know it from a different perspective. I mean, I've had circumstances where you've got somebody whose family members, someone might need to be conserved. They get to that point where they might need a conservatorship and they might need to have placement in a facility because they have a tendency to wander. Now, you can have 24/7 care providers in their home because people desperately want to live at home. But if you're talking with their trustee or someone professional fiduciary who's managing, or a family member that might have taken over, or talking with them, that you might have to have that conversation that you might not have the resources to last that long because folks, you got two people, they've got all the people in the home that are taking care of the home, the gardener, the caretaker, the housekeeper, and so forth. And now you've got professional care custodians, care providers, that can get to be a nut to cover every month. And it's just hard to have that conversation with someone that we have to maybe think about moving from home to moving to a place that is more economical, because people perceive that's the last place they're going to be, and it's an emotional time that many times we all might face that. I'm sure you run into those situations. I wanted to dovetail into another conversation. Elders are vulnerable. I'm glad that you have a vetting process. I deal with cases where unfortunately, there are people in roles of proximity and trust, and it's not uncommon to have care custodians or care providers wind up, if they are not doing the right thing, to wind up on the other end of an adverse legal action if they are the inappropriate recipient of benefits or inheritances, or there's all kinds of laws in the California probate code that speak specifically against that. People might want to know, do you have family members might want to know, hey, if we leave mom or dad in with your folks, are you careful to let your people know that they're not supposed to be ingratiating themselves with mom or pop and getting into their finances and so on and so forth. That's not an accusatorial question at all. It's just like probate court in Southern California a couple times a week, and those kinds of things just come up all the time, and it's just a rampant thing. And we know probate code 21380 speaks to the presumption that if someone winds up as a care custodian in someone's will or trust, it's presumptively invalid at the first level. So what does, at the end of, we could argue whose responsibility it is or not, but do you do anything to alert your people to say, hey, look, we're here to take care of people, and that's it. We're not to go beyond that. What boundaries do you set, and how do you vet people? Do you have a policy of telling people what is not appropriate when they're dealing with the elders?
Yeah, it obviously starts from the very beginning of just who you're vetting and who you're bringing on your team. And I'm happy to go through our vetting process, but for the sake of time, I'll just jump right to the answer. When we are actually nurturing our new clients, one of our questions is, who's handling the money? Caregivers do handle clients' money. Okay, so what's going to be our process for that? We love something called the TrueLink card. They can load money onto the card, and they can even state on that card where the monies can be spent. So if it's only grocery stores, that's the only place a caregiver can go. So we designate our clients to please try to do that. They have to set it up though. So it's if they're willing to go through the process, that's our best case scenario and the most control.
What you're saying is there are protections that can be put into place that will create barriers so that you don't even, not to say that anyone on the team would be inclined to do anything wrong, but I'm speaking broadly, and I have a lot of respect for people who provide care to elders and do all of the things they have to do every day to make sure those elders are happy and clean and fed and all of those things. But if they have to go to the grocery store, they're going to have a card that says it's only for groceries, and it can be tracked, and you're not buying groceries for them or somebody else. You're buying it for the household in which you're providing services. So you have those mechanisms available to you to deploy in the care of the elder.
Yep. And then we require them to document where they shopped and what they spent. I don't care if it's $1. They need to document. I went to Stater Brothers. I spent $1. They have to email us the receipt, or sometimes the family just wants an envelope in the home so that the receipt is there and captured. As far as gifts giving to the client, I allow it, but my policy is I need to know about any money exchange that happens between. And I do like to have limits, although some of them don't like to do that. But that is a very gray area because they grow to love their people. But I don't like any gray. We're the professionals. I just don't want that area to be crossed. You know what I mean?
Yeah, there's again, I don't want to have a legal analysis about that, but there is nominal tokens or something like that might be one thing, but something that's of a substantive nature is quite another. And it is extremely important for the agencies to be aware of these things. And because so many times You don't have to go very far to find cases where people push the limit or people don't do anything, but someone wants to give them something because they're lonely, they're starting to have neurocognitive disorders, they're
Right.
not remembering, they're making mistakes about who someone is in their life. Their generosity level goes up to a degree that is not historically what they would ever do. And it's just not something that someone in the role of a trusted provider should even accept. That's my view. I take a fairly hard line in it, but because I know what the penalties of the law are going to prescribe against someone who crosses those lines. But it sounds like you've got a meets and bounds and barriers to make sure that people are dealt with appropriately at all times, and that's a good thing. A couple of practical questions. What do you do? And we touched on this before, and I don't want to reiterate it too much. What do you do when when it's time for them to maybe go someplace else? How do you have that conversation with someone?
Yeah.
If it's maybe, they like, look, this is too much for you. It's going to be burdensome. You're really going to be better off maybe in a facility, or maybe it's time to have that conversation with a family member. They probably, if someone's a wanderer or they're starting to have deep, if it's an Alzheimer's condition, it's advanced, and maybe the in-home arrangement is not practical because of the family resources, and they have to go to a facility, a memory care unit. I'm not talking about the legal stuff or anything like that. I'm not able to do that. But how do you approach that conversation?
I will pride myself. I think our approach with our clients, first of all, they trust us and they do view us as the authority. So I think I've got leverage there. By the time it gets to that point, I think they really respect that we actually are coming to them even with that, because we're a business. The easier thing would just let them kind of tread water. But I'm not like that. That's not what I told you, we're solutions focused. The thing is, it's the guilt. That is really what they're dealing with. It's the guilt. They feel bad that they've got to move mom to an assisted living or look at a different care option besides, because they promised mom you will never have to leave the house, even if the financial resources are there to stay there 24/7. But daughter who lives out of state or even local is trying to raise her own family and live her own life, feels extremely guilty because I promised mom. But it's helping them and giving them the permission that it is no longer safe. You promised her, but your mom keeps falling or whatever. We could go through every scenario. So that's the approach that I love to take. Or they're hurting themselves, advanced dementia, where they're extremely violent to others. They're going to hurt my team. You know what I mean? And what we're having to do is snow them with these antipsychotics because their dementia is so bad now. What kind of quality of life is that? Honestly, too, we ease into it. And it's not just like they need to go tomorrow. And we give them some of our local ones that we have vetted that we think are great solutions to them.
It's complicated. It's nuanced. There's not one size fits all to any of these situations.
Right.
It's fluid. You see it in a practice where you're representing, just related, you might be representing someone who is a titan of the business community in their life, but now they're having to accept the fact that they do need a private professional fiduciary to help them, that they do need maybe to stop driving. They don't want to do that. They have to do that. And I won't say it's a conundrum, but it's something that as a legal professional, as a lawyer working with clients who have some of those circumstances, or clients whose family members have those circumstances, it's humbling. And you really have to draw down on not just the technicalities of the law and the roads, the regulations, and the business aspects of delivering something to someone. You gotta empathize with a person's situation and their life trajectory of getting to that point.
Absolutely.
And it sounds like you do have a heart of gold. And that you do have empathy, and that you do have mechanisms for outreach and connection and transparency and communication, which is all a part of providing in-home care. And I want to thank you for being with us today. We've went a little bit longer than you usually do, and this is just scratches the tip.
Right.
It's just the tip of the iceberg, because it's a transitional moment in the lives of the cared for individual. But it's also a transitional moment in the lives of the people, the family members. Like you say, the lady who, I want to do what's best for my mom or dad. This is what they want, but they can't do something anymore. Even introducing a care providing team to their house might be resisted at the front end because they don't think they need it. Mm-hmm. And they have to be brought on board that it's a good thing to do. And then you get to the next level. So delightful conversation, interesting, really appreciate your time and the insights that you give to the day-to-day workings of in-home care. Thank you very much, Jenny. I appreciate it.
I love it. Love talking this stuff. So thank you so much.
Yeah, we'll have you back again. We'll maybe focus on some more specific, nuanced issues that arise. That's all for today. We'll see you next time on Your Inheritance.
You've been tuning in to Your Inheritance, your rights, your obligations, your responsibilities, with your host, Peter Bochnewich. If you're being sued over an estate or if you feel you're not getting your share, Peter's firm can help you. You can find this show at www.betrustlaw.com and on YouTube, Facebook, Apple Podcasts, Spotify, Google Podcasts, and more. Thank you for your positive feedback, comments, questions, and for sharing the show with others.